Hi, my name is Dave Hashey, and I'm a pharmacist and professor with the Idaho State University Department of Family Medicine. In this unit, we're going to be discussing sexually transmitted diseases, or STDs. I have no financial disclosures. However, I do want to make you aware of a resource that's available for smartphones, tablets, that is a STD treatment guideline. And this is accessible on the Apple Store or Android apps. This unit is a fairly involved unit in which we're going to be exploring the most common STDs found here in the United States. And as part of these objectives, it is to describe some of the regional and national epidemiology of chlamydia, gonorrhea, syphilis, and human papillomavirus, or HPV. Also, as a learner, you should be familiar with different screening methods and confirmatory testing. Identify resources for patients with a diagnosed STD, and be able to recognize common medications used to treat STD. Finally, from a public health perspective and provider approach, you should be able to provide different harm reduction strategies and resources for persons at risk for contracting STDs. So let's start with chlamydia. Chlamydia is a sexually transmitted bacterial infection, which, as you can see, over the last 30 to 40 years, has been increasing, steadily increasing. There is no vaccine for chlamydia, and because of its ease of transmission sexually, have seen ongoing incline. And during 2020, during the COVID pandemic, a lot of STD reporting dropped off because of the resource allocation and shifting to COVID. And this is a comparison of age groups and gender, males on the left, females on the right, and age groups going all the way up to 65. And what you can see here is that the rates of chlamydia tend to be higher in females and disproportionately affect the younger individuals. Those between 15 and 35 have some of the higher rates, tapering off in older adults. Secondarily, you can also see higher rates of chlamydia in patients with different races or ethnicities. Black individuals tend to have higher rates, and again, a lot of this can be described and identified by differences in social determinants of health, whether it's distrust of healthcare systems, lack of access to care. A lot of these issues can manifest in different races and ethnicities. The geographic distribution of chlamydia is, as you can see, more prevalent in the Southeast. This also mirrors the HIV epidemic in the United States. And again, a lot of this is seen in rural communities, African Americans, those with poorer resources or access to care, and sometimes lower socioeconomic status. As we've seen the transmission rates of chlamydia increase over the last several decades, it's important to note that this bacterial infection is highly transmissible, not only in the genitals, either penis or vagina, but also rectally and oropharyngeal. So patients can have infections if they engage in different types of sex, such as receptive anal intercourse or receptive oral intercourse. And it's important when talking to patients about their sexual practices that we ask where they have sex, which orifice, whether oral, rectal, vaginal, or penile. Symptoms of urogenital chlamydia are often asymptomatic in males and females, but unfortunately, if undiagnosed, can continue to cause pelvic inflammatory disease or PID in females. When the infection site is oropharyngeal, or in the throat, or in the rectum, those two can be asymptomatic, making it difficult to diagnose or for patients to seek care. So testing has shifted a little bit in its testing methods from what is referred to as culture-based methods to more advanced molecular-based techniques. This change of getting a specimen and trying to grow out the bacteria to actually looking for genetic components of the bacteria has increased the sensitivity and accuracy of the test, as well as made it easier to collect the specimen and test different sites. These molecular-based testing methods are usually referred to as NAAT or NAT testing, which stands for nucleic acid amplification testing. And again, this is preferred because it is going to be more accurate with higher sensitivity, specificity, and being able to be performed on different specimens. The other aspect of the importance of this testing is for patient self-collection. There are studies that suggest that patient self-collection, whether oropharyngeal or rectal through the use of a swab, is accurate and supported when done in a clinical setting. The screening recommendations set forth by the CDC are based on gender and sexual preferences. For example, women who have sex with men are recommended to be screened for chlamydia starting at a younger age, and for those less than 25, annual screening is recommended. Those 25 and older, if they are at high risk, such as multiple sexual partners, should be screened more frequently or annually if at higher risk. Women who have sex only with women should have the same screening as those who have sex with men. And for pregnant women, testing should commence at the first prenatal visit and in the third trimester for those less than 25 and those older than 25 with risk. For men who have sex only with women, routine screening is not recommended. And this can partly be reflected by rates of disease in men who have sex with women. However, in men who have sex with men, there are high rates of sexual transmission, not only genitals, but also rectal and oropharyngeal, based on sites of intercourse. And so regardless of condom use, patients should be screened at least annually and more frequent testing if at higher risk, such as multiple sexual partners or symptoms. Transgender and gender diverse persons should be screened based on the person's sexual practice, age, and genital anatomy. And finally, patients living with HIV should have annual screenings or more frequent if at higher risk. For patients who test positive for chlamydia, the treatment regimens have changed over time based on primarily patterns of bacterial resistance, as well as more data on efficacy of outcomes and location of infection. When we look at treatment regimens for chlamydia, the primary recommended regimen is twice daily doxycycline, 100 milligrams, for 7 days. If patients have an allergy or there's a drug shortage or difficulty accessing that, alternative recommendations would be azithromycin 1 gram as a single dose, or levofloxacin 500 milligrams once daily for 7 days. Generally, test of cure is not recommended for non-pregnant persons, but in pregnant individuals, test of cure should be performed. In regards to management of sexual partners, this is where it can be challenging as one person goes in for evaluation, but they have a sexual partner who may also have the disease and continue to transmit if that person's untreated. Therefore, all partners should be evaluated that have been engaged in sexual activity within the past 60 days. And the principle of expedited partner therapy is an option for those who are either unable or willing to be evaluated. For example, patient A is diagnosed with chlamydia. their partner, patient B, cannot get in to be evaluated, it is appropriate for the provider to prescribe medication for patient B for expedited therapy without reviewing or evaluating that individual. Important counseling and education points for chlamydia are severalfold. First, patients should abstain from sexual activity until they have completed therapy for at least 7 days of either doxy or 7 days after the azithromycin. Partner notification is really important, and in some states, contact tracing and partner notification may need to take place primarily by public health personnel. But as providers that are diagnosing this, this may also be reportable to your local state's Department of Public Health. And it is important to report these and notify patients so that individuals can be treated and we can reduce the spread. Follow-up testing for chlamydia. So patients should be evaluated 3 months to have repeat STI testing. Gonorrhea, a lot of times we say goes hand in hand with chlamydia. These two bacterial infections are very common and may be transmitted together. However, there are some unique differences, but in regards to some of the epidemiology, there are similarities. So just to quickly go over them, the similarities we see with chlamydia are transmission risk as far as sexually, and as far as engagement either with men with sex with men, sex with women, and so forth. Testing is very similar, as is screening and follow-up and education. So let's look a little bit closer. Rates of gonorrhea going back to the 1940s have ebbed and flowed, and from 1995 to about 2015 remained fairly steady. However, over the last 10 years, we have seen significant rises in gonorrhea, much of this also explained by treatment-resistant gonorrhea. In comparing rates of gonorrhea between men and women, this does differ with chlamydia, as gonorrhea tends to have higher rates in men. Looking at the age distribution, this is an infectious disease that affects primarily those who are younger, in their 20s and 30s. However, it can infect anybody, any age of the spectrum, based on sexual activity. Rates of gonorrhea also similar in regards to racial and ethnic distribution. And you can see geographic distribution is also fairly similar, with more concentrated rates in the South and the Southeast. Treatment is slightly different for gonorrhea compared to chlamydia. And first, we're going to differentiate location of treatment. So first of all, uncomplicated gonococcal infection of either the cervix, urethra, or rectum, the primary recommended treatment regimen is an injection of ceftriaxone 500 milligrams as a single dose for individuals weighing less than 150 kilograms. Not every patient is going to have chlamydia tested, but if chlamydia is suspected, it would be important to treat the gonorrhea infection with the ceftriaxone and add doxycycline 100 milligrams twice a day for 7 days, as the ceftriaxone does not cover chlamydia. During pregnancy, 1 gram of azithromycin is recommended to treat the chlamydia as well. If ceftriaxone is not available for a patient, it would be important to use a different injection of gentamicin, 240 milligrams, and azithromycin to treat that. If unavailable, there is an alternative all-oral regimen, which is Cefixime, 800 milligrams, given as a single oral dose. Treatment of uncomplicated gonococcal infections of the pharynx is similar in that the recommended regimen is ceftriaxone 500 milligrams, IM as a single dose. And if chlamydial infection is also identified with this, the addition of doxycycline twice a day for 7 days is recommended. Now, one of the shifts in gonococcal infections that we have seen that have changed the treatment guidelines has been with the evidence of increase in treatment resistance over the last 15 years with azithromycin. As you can see, the rates of azithromycin resistance have increased, as have with fluoroquinolones. But cefixime, ceftriaxone, still is very effective in treating STIs and STDs. Shifting now to syphilis. Syphilis is a bacterial infection caused by Treponema pallidum. And syphilis can be a very complex disease to understand, diagnose, and treat. And in this unit, we're just going to cover some of the superficial highlights of syphilis. The history of syphilis can be a little bit complicated based on how a person presents and when they present. After acute infection, the first time period with infection is called primary syphilis, followed by secondary syphilis and then latent syphilis. These happen at different time periods after infection, as patients may not always seek medical care after primary infection. Some stages may have symptoms, others may not. However, as the disease progresses, tertiary syphilis may occur, and what is also important to note is that either neurosyphilis, ocular, or otosyphilis can occur at any stage of illness. When we look at the natural history going back to the 1940s, we can see that there was, again, a large amount of syphilis back in the 40s and 50s. However, this was able to get under control and remained fairly stable from the 2000s to about 2015. At that point, we started seeing larger rises in transmission and cases of syphilis, and a lot of this now, as we look at the last 20 years, you can see the gradual increase in all cases of syphilis in the U.S. When we look at the distribution based on sex and sex partners, the primary group that is predominantly affected are men who have sex with men only. This accounts for over a third of all cases. Females account for about 20%, as do men with unknown sex partners and then men who have sex with women. So with this, again, the major population of increasing cases are men who have sex with men only. And as one would expect, the rates based on age and sex, males, higher rates of disease, nearly 5 times that, 4 to 5 times that of females. And then looking at age distribution, again, 20s, 30s are the highest rates. Again, Blacks, African Americans have the highest rates of disease compared to other ethnicities, but there is not as significant of a gap as we see with other races or have seen with other diseases. And when we look at distribution of syphilis across the U.S., it does have a slightly different geographic distribution, looking at higher rates in the Southwest and the West Coast in Seattle, Oregon, California, Arizona, but also still some high concentrations in the Southeast, including Florida and Georgia. And then when we look at congenital syphilis, so syphilis may also be transmitted at birth, you can see we have seen higher rates of syphilis occurring over the last several years. And clinical manifestations of syphilis vary based on stage of disease, and it's beyond the scope of this unit. However, usually in primary syphilis, there's going to be symptoms. There could be an asymptomatic chancre on the genitals. There may also be rashes on the palms, soles of the feet. And because of this, the patients may seek medical attention, or because it's asymptomatic, they may not even notice it. For patients who are diagnosed with latent syphilis, where there tends to be no symptoms, but the duration is less than a year versus greater than a year, that may impact treatment, as we will see shortly. And as far as neurosyphilis, ocular otosyphilis, that can occur anytime the bacteria gets into the central nervous system, causing some changes such as headaches, visual changes, auditory changes, and other nonspecific CNS manifestations. When we talk about testing for syphilis, there are several different lab options that may present themselves. And depending on the area that you practice or the lab that is testing the specimen, they may have options to different treponemal or non-treponemal tests. The tests you can see, the VDRL and the RPR, the FTA, the TPPA, those are going to be your most common laboratory tests. And when we look at sensitivity, the sensitivity of these can vary based on the stage of infection that a patient is experiencing. However, the specificity is quite high in all the tests, and so with this, all the testing, regardless of the testing, has a fairly strong positive predictive value, and there are few episodes of false negatives or false positives. The national screening recommendations for syphilis from the CDC are broken down into gender categories and sexual orientation categories. First of all, men and non-pregnant women, because of the low rates, routine syphilis screening is not recommended for only men who have sex with women, non-pregnant women who have sex with men, or non-pregnant women who have sex with women. Because of the higher rates of transmission and disease prevalence in men who have sex with men, annual screening is recommended, and more frequent screening every 3 to 6 months if there's ongoing risk at acquiring syphilis. Women who are pregnant, testing should be performed in that first prenatal visit and retesting at 28 weeks of gestation. And any woman who delivers a stillborn infant should have testing at 20 weeks of gestation, should have serologic testing. And screening for syphilis should occur in every pregnancy. Persons with HIV who are sexually active should also have testing at their initial visit and then annually, or more frequently should they be having higher risk, more sexual activity, new sex partners, unprotected sex, etc. Transgender and gender diverse individuals should have screening considered at least once a year based on their reported sexual activity and risk for acquiring syphilis. When we talk about treatment of syphilis, treatment has generally not changed in the last 80 years. It is penicillin. Penicillin is still very effective. However, the penicillin has to be delivered via injection. And for patients experiencing either primary, secondary, or early latent syphilis, the recommended dose is penicillin G, 2.4 million units given as a single dose one time. Usually acquiring that is going to result in a patient visiting either a health department for administration or a clinic for administration. And the other problem with this is that there have been national shortages of penicillin in the last few years, and because of that has sometimes deferred providers to look at second-line treatment options. When we look at late latent or tertiary syphilis, the only difference is it's the 2.4 million doses. given once a week for 3 weeks. So spacing those out at 1 week intervals, having the patient return to clinic or return to the site of injection every 3 weeks or every week for 3 weeks is important. For individuals diagnosed with either neurosyphilis, ocular, or otosyphilis, when the bacteria gets into the central nervous system, it's harder for the drug to get there, and therefore those individuals need penicillin given as an IV infusion every 4 hours for 10 to 14 days. That usually requires more coordination with an infusion therapy or just to ensure that the patient is able to complete therapy. After a patient completes therapy for syphilis, those individuals should have antibodies detected in the blood lifelong and therefore need what is called repeat titers to make sure the level of syphilis has come down appropriately. That is what's referred to as routine titer monitoring, and patients also need to be monitored clinically to ensure that the disease has resolved if they in fact had symptoms. In regards to management of sex partners, this is a little bit different compared to patients with chlamydia and gonorrhea. Expedited partner therapy is not recommended, and in that case, those sexual contacts should undergo full evaluation, testing, and treatment if indicated based on the type of syphilis they have. Patients may resume sexual activity when 7 days have elapsed since completing their therapy and all mucosal lesions have healed, and sex partners have also been treated for syphilis. If their sex partners have not been evaluated and treated, they may reinfect the recently treated individual. The final STD that we're going to talk about is HPV, or human papillomavirus. And why HPV is so important is because HPV is not only a viral infection, but can also lead to the development of certain cancers. When we look at cancers associated with this virus in the US between 2013 and 2017, we've seen that the major cancer in females is cervical cancer, but also you can see oral pharynx, anus, vagina, and vulval cancer as well. In men, the major cancer related to HPV is oropharyngeal cancer, but also anal cancer and penile cancer. So with HPV, it is a virus that not only can cause warts, but can also cause cancer, and therefore the screening and prevention is really important. There are different types of this virus and subtypes. There are types that are non-cancer causing. These are referred to as low-risk types. These are ones associated with genital warts or low-grade cellular changes. And about 90% of genital warts are caused by HPV subtypes 6 and 11. The high-risk ones that cause cancer, primarily 16 and 18, but also 31, 33, 45, 52, and 58. These are the ones that are targeted with the vaccine. When we look at peak prevalence for each stage of cervical cancer, a lot of this, when we look at the female population, the HPV infection usually happens early after sexual debut, late teens, early 20s for most females. And there can be this changes in these cellular changes from normal changes to HPV positive. HPV can cause cellular changes in the skin, and that can sort of have this progression as the body tries to clear the virus. However, once the cellular changes progress to cancer, that's where we see those higher rates begin to rise in the 30s and 40s. So screening for HPV is different based on gender, age, and there's different testing types. For patients with anal genital warts, those are usually diagnosed clinically. Patients a lot of times will complain of discomfort or changes in tissue around the anus. In regards to cervical cancer screening, those are generally diagnosed with the appropriate cervical cytology testing, referred to as the Pap test. And depending on the age of the patient, there may be what's referred to as co-testing. We're not only looking for changes in the cell lines, also looking for virus itself. Screening for anal cancer is done by digital rectal exam by a medical provider. And if there is suspicion, there can also be, in certain circumstances, anal cytology and looking for HPV around the anus. Right now, there is no FDA-approved use of anal specimens, but there are certain clinics that providers may be trained in how to screen with high-resolution anoscopy and other testing methods. The main route of prevention is with the HPV vaccine. The HPV vaccine is a highly effective vaccine at reducing rates of cancer. As we know that HPV acquisition occurs soon after sexual debut, most often in young adults, HPV vaccine should be administered to young individuals, and we'll look at specific age ranges based on gender here shortly. In data from the 90s up until about 2020 demonstrate a decreasing incidence in cancer, death, and disability, but cervical cancer is still one of the most common cancers seen in women. When we talk about the efficacy of the HPV vaccine, nearly 100% of patients that are vaccinated will have a positive seroconversion and protection from the vaccine. Some individuals state that I don't want a vaccine, I want to have natural immunity. The problem is not everybody who contracts HPV will develop immunity. Matter of fact, it's roughly 50% for females and males. Therefore, this is one of the disease states that it is important and relevant to receive vaccination. And when we look at the rates of not only cervical cancer prevention, but we also see a reduction in genital warts, we see a reduction in anal condylomas, and we see a reduction in both low-grade and high-grade changes. The HPV vaccine should be given starting at ages 9. And in those age 9 to 15, it's recommended 2 doses at time 0 and then again at 6 to 12 months. For those patients in age 9 to 15 who are immunocompromised should receive 3 doses because they may not have as strong of an immune response. In patients age 15 to 45 who choose to undergo vaccines, those individuals will need 3 doses. And the vaccine has strong recommendations up to individuals age 26. For those 26 to 45, usually shared decision-making with a medical provider on the benefits and risks of the vaccine should take place. This is another look at prevalence of HPV for subtypes for females age 14 to 34 by age group. And what we can see is over the last 20 years, the reduction in disease primarily seen by the introduction of the vaccine. So to bring everything back together in regards to STDs, hopefully after completing this unit, you're able to list the most common STDs that we see here in the U.S., being chlamydia, gonorrhea, syphilis, and HPV. Understand some of the different screening and testing strategies identified with these based on age, gender, sexual orientation. Identify care resources for persons with STDs. common medications, and different harm reductions and approaches for those. Thank you.